Alrighty, so as we get into part 2, we really went over the neurophysiology of pain, and there were some really important concepts that we went over. So number 1, remember that perception of pain is brain-based. Number 2, pain does not equal the amount of tissue damage. Number 3, many physiological and psychological variables impact pain perception. And number 4, chronic pain is due to activation of pain pathways, lack of activation of pain inhibitory pathways, or both. And then you have nociceptors, and nociceptors are activated by multiple different chemical mediators. And the more chemical mediators that are involved, the greater sensitization happens at the nociceptor, and the greater potential for pain perception, the greater potential for peripheral sensitization, the greater potential for central sensitization. And when we look at these pain fibers, we have A delta fibers and C fibers. And C fibers cause that burning pain, and then the delta fibers not only carry pain, but they also carry temperature. And we talked about 3 order of neuron pain pathways. So we have the primary first order neuron that takes information from the nociceptor to the spinal cord. Then we have information from the second order neuron from the spinal cord to the thalamus, and then from the thalamus to the cortex. Now the patterns of referral pain, like visceral referred pain or somatotopic pain, happens because we're getting more input from somatic tissues, muscles, joints, ligaments, and from viscera. So when these convergence pathways from primary neurons hit secondary neurons and eventually tertiary neurons, it gets interpreted as they're coming from these areas of the skin and joints, and that's the mechanism for referred pain patterns. And then we also talked about the spinal cord, and the spinal cord has nociceptors that come in and hit the posterior horn of this. And chronic activation of these nociceptors has an impact on causing central sensitization by the NMDA receptors. And when this starts to happen, people have increased exaggerated pain responses, and that's part of peripheral sensitization. And then we also talked about pathways coming in from mechanoreceptors, and mechanoreceptor outputs through A beta fibers are much more, actually much faster than C fibers because they're myelinated. So, this is when you hit your hand and you shake your arm, that's getting those mechanoreceptors. So there's a proprioceptive input that comes in from the brain at the spinal cord level. And also at the spinal cord level, that impact from nociceptors activate the sympathetic ganglia, and the sympathetic ganglia then increases the sympathetic. So every time you fire nociceptors, you also fire sympathetic nerve pathways. And we also know that when we look at pathways of ascending pain, we have areas of the brain like the somatosensory cortex, which then localize the pain, but then areas of ascending pathways go into the limbic areas and areas of the insular cortex and the cingulate gyrus, which then impact our suffering and our autonomic responses that can take place with pain. And then our brain has this descending pathway where the cerebral cortex activates the periaquedural gray, which dampens spinal cord pathways. And this loop you can see right here, right? So noxious stimuli fire dorsal ganglia. This fires up to the brain. You can see it fire to the somatosensory cortex. You can see it fire to the hippocampus for memory of pain, the amygdala for suffering and pain. Then the cortex fires into the periaqueductal gray all the way down to the spinal cord to inhibit that pain. So the normal dynamics of pain mechanisms is really receptors get activated. They fire this first order neurons to the spinal cord fires up to the cortex then excites inhibition to dampen pain. So this is where unhealthy brain function can really impact pain. So the case where we have the patient where she had hyperalgesia, and then we had some brain activity, and all of a sudden her hyperalgesia went away, that's this pathway being activated. I mean, you can see it in real life, real time, when you activate the brain. Then we went over the different regions of the brain. So remember that the somatosensory cortex, the parietal lobe, is involved with locating where the pain is in the body. The insular cortex involved with discriminating sensory perception of pain, burning, stabbing, dull ache. The amygdala is involved with the experience of emotional suffering of pain. And if the amygdala is already activated, like someone is depressed, someone has PTSD, someone has emotional mechanisms that are activating their physiology, and then they have nociceptive inputs come in that can really exaggerate their pain response and their sympathetic response. The intercingulate gyrus is really involved with the intensity of pain, and it also helps with modulating that periaqueductal gray. Prefrontal cortex is very important for activating that periaqueductal gray, that descending inhibition pathway. And then that periaqueductal gray in the midbrain fires into serotonergic pathways that then dampen spinal cord pathways. Nucleus accumbens is where you release natural opioids to dampen, to help reduce pain. And the hippocampus is where you store the memory of pain. So then we went into, the difference between acute pain and chronic pain. And acute pain is, really linear, and you just try to remove the stimuli. And when you have acute pain, the goal is really to try to find as many different metabolic chemical mediators that also are activating nociceptors and to remove those. And then when you look at chronic pain, you're trying to there's no starting or beginning point, it's just a cycle, and you're trying to unwind this cycle. And then we went into different perceptions of pain: hypoalgesia, nociception, hyperalgesia, allodynia. These you can simply do with just like a pinwheel exam. If you don't have a pinwheel, you can just take a paper clip and use one side of the paper clip and have patients feel it. A lot of times I'll have patients take a paper clip at home and just tell me how they feel from one side to the other, and I'll follow up like on a Zoom call. And then they can, if they had hyperalgesia in one side of their body, they can just take a paper clip and do it. Or if their spouse is there, they can just quickly stroke it and see what they feel like and see if it's calming down or getting worse. Or they have allodynia, you can just simply touch it and see if those mechanisms are changing. And then we went into the concept of metabolic variables that impact pain. And we said there's amplifiers of pain. So when someone has a 5-pound, let's say, trauma, it's going to cause pain. But if they have, histamine and other sensitizers like adipokines and insulin and glycoside end products, that can amplify the pain. And then if they have inhibition, if they have lost or descending inhibitory pathways, that can increase pain. And at some point, there can be no trauma, and their pain pathways can fire on their own, and that is basically sensitized pain. So with Nico, with the case study, he's having pain firing all the time on his own. He didn't have any nociception, and then his body would go into tremendous pain patterns. Those are centralized pain. The areas of his brain were firing as like his limbic system, somatospheric cortex. He was feeling pain because he had an injury. His autonomic system would fire on its own, and he would just perceive pain there was no actual injury to those tissues of. And then when you're looking at inflammation and chronic pain, whether it's at the peripheral nerve or at the brain, any pre-existing factors that activate microglia towards an inflammatory state also have a factor in causing ongoing pain. And then we talked about the connection between pain and energy. And we talked about how normally you have a resting memory potential at a distance away from threshold, but when people start to have mitochondrial impairments, they don't have the energy in their neurons to pump out sodium and activate the sodium-potassium pump and pump out calcium. Those are things that happen during depolarization. So neurons get close to threshold, and then those activate pain patterns. And then we went into conditions like fibromyalgia. And fibromyalgia is basically sensitization of pain, especially muscle pain, in combination with the things we talked about with ME/CFS, where they have muscle metabolic issues, or they're in a Warburg response, or they just have mitochondrial impairment in combination with nociceptive activation pathways that are then leading to fibromyalgia type symptoms. Very, very general. Then in part two, and then in the next section of part two, we went into the clinical evaluation of pain syndromes. We talked about, there's pain conditions that have active nociceptor stimulation, and then there's pain conditions where there's no longer any nociceptive stimuli, but they still feel pain. And we then discussed different types of pain. So degenerative joint pain versus sclerotogenous pain, which is from ligaments, myofascial pain, from fascia constriction of myofibrils, nerves and blood vessels, metabolic muscle pain, neuropathic pain from nerve injury, vascular pain from chemical-mediated vasospasm, viscera-referred pain from conversions of soma and visceral pathways. And then I took that migraine. Migraine is a totally separate mechanism. We can have to have our own module on migraines. There's a lot to talk about. It's different than this. neuroendocrine immune vascular phenomena that's complex, but we'll do that at a different time. And then when you look at pain, these different types of pain patterns, they combine with nociceptive amplifiers, and then those things intensify pain. So when you have someone who's got chronic pain or really intense pain, you're trying to go through their history and figure out each one of these little different triggers and reduce them so you can decrease the amplification of their pain. And then we also talked about when you're dealing with pain syndromes that you have to have this balance between nociceptor amplifying sensitizers in relation to their natural opioid responses, right? So you want to decrease nociceptors, you want them to do things like physical exercise, laughter, have healthy relationships, follow pursuits of passion, volunteer, do things that actually raise their opioid levels. Those can also be important for pain. Easiest thing for people to do would be just to get some movement in, do things to make them laugh. Hopefully they're in healthy relationships. Hopefully they have intimacy in their life. These things can all have an impact on their opioid responses. And then remember that there's some direct relationships between pain and brain function. So the brain basically activates descending pain pathways and suppresses sympathetic tone. So when the brain's not healthy, you can have these different types of catecholamine, neurogenic inflammatory responses, or pain perception. You're just simplification of the same thing. So you're showing the brain dampens pain through descending pathways, the brain dampens pain through hypothalamic spinal tract pathways as well. And then we went into clinical treatment of pain syndromes, and we said, okay, well, when you look at pain syndromes, these pain syndromes that are constantly active nociceptors, you're looking at a linear model. In the linear model, you're basically trying to look at reducing the amount of amplifiers versus opioids. As a matter of fact, you're doing three things. You're looking at nociceptors, amplifiers versus opioids, healthy brain function versus unhealthy brain function, and then healthy sleep versus unhealthy sleep. These are key things that are required for that linear model of reducing the transmission of pain. Then we talked about chronic pain patterns. And with chronic pain patterns, we have this overlap of fatigue and energy. And ultimately what you're trying to do is trying to manage things that overlap between these two clinical management models. And this is where exercise, sleep, and diet come in. And as you look at merging these things together, you can have the greatest influence. We talked about there's no way out of a fatigue or pain syndrome unless they exercise. And then sleep is critical, and then diet's critical. Sometimes you got to treat mechanisms in the fatigue pattern to get people there, and sometimes you can go ahead and jump with it. Like an example, with Nico's case as a case study, you can only do 5 minutes on a bike at first. And as a matter of fact, what we had to do is we couldn't actually have him exercise at the beginning. We had to put him in ketosis, get his brain inflammation down, and then he could start with 5 minutes. And then he had to keep going and working his way through. Now, here's the thing. If you understand these mechanisms, then when they come back to you and say, it's been 2 months, I'm not feeling better yet, you can look the person in the eye and say, keep going. You're not there yet, okay? And that ability to understand these mechanisms and have that confidence with the patient is what you need to have as a clinician to get people where they need to go. Like chronic disease conditions don't turn around overnight. When you're dealing with chronic diseases, chronic patterns, vicious cycles, it's unwinding. Unwinding takes time. If you're not confident in these mechanisms and understand them, then you kind of keep trying new things and new things and new things. And this is why practitioners fail with chronic patients. Since they don't understand the mechanism, they don't see that change happen immediately, and then they try to do something different. That's a huge difference. And especially with practitioners that treat acute pain all the time. Practitioners that treat acute pain suck at chronic disease because they're so used to doing something and seeing the immediate change. When people that work with chronic disease and chronic conditions, they realize that there's a process that they have to go through, an unwinding that has to take place. And over time, they get experience doing it more and more. So when they work with their patients, the level of confidence that the patient sees in their practitioner saying, you need to continue, you're working through this, gets the patient to go, okay, I think he's very confident about this. And then you say, what other options do you have? Just keep going. And that really gives them what they need to do to make a big difference. So those are the key concepts that we talked about in part 2. Okay, let's get into questions. Okay. If your question wasn't answered and you sent in questions, we'll make a post-conference video to answer the questions that were sent in. So don't worry about that. Okay, let's go into here. Question. Are children born with neurodevelopmental issues or on the autism spectrum more prone to struggle later in life with intermittent and chronic fatigue? Yes, it depends. So here's the thing. We're going to talk about this in the next module. But when you look at neurodevelopment, you have gray matter and white matter. Gray matter fully develops by age 6 to 7. White matter fully develops by age 18, 19, 20, 21 at that point. Whatever you don't change by that time period is going to be permanent to some degree. So that's when you get adult ADD, adult ADHD. They never develop the brain out of it. That's when you get an autism that never had a chance to recover. So there is people don't like the term, but there is a ticking clock. When you have a child with developmental disorders, the current model is, they'll just grow out of it. That's not good enough. Like if you have a person that's suffering from developmental disorder, you go, why is their brain not developing? And we'll talk about all the things that impact development, all the things that you have to do to improve development, difference, what's happening with autism brains versus ADD brains and dyslexic brains. We'll do all that in the next module. But you really want to get in there and make a change as soon as possible and get that brain and connectivity and the development and plasticity and myelination and neural migration all happening so they don't end up with persistent symptoms throughout their life. It's very realistic to take a patient with ADD, ADHD and improve their brain function, and before their brain fully develops, they're done. They don't have those symptoms anymore. Autism depends on how severe it is, but you can make some really big changes with many cases of autism. So if you don't capture treatment in that window of time, then there's definitely problems with struggles later in life because of fatigue issues and brain activity as well. Okay, next question. I've seen a few older patients decline rapidly in health after giving statins. Can older patients reverse these effects? So a lot of times statins can cause lots of different things. The model that we talked about is statins can cause mitochondrial uncoupling. So, most people think of statins as the possibility to cause that severe muscle pain, muscle breakdown tissue, and if that's the case, that they should go off statins. But studies show, like when people go on statins, even if they don't have muscle pain and the symptoms associated with that adverse effect, mitochondrial output gets reduced by 30 to sometimes 60% with people on statins. So yes, they can have some health problems. They typically totally normalize once they go off the statin within a couple of weeks. And, they may need some time to. So remember, if you have mitochondria that's not working, then postsynaptic effects take place. So as soon as you remove the statin, if that was the mechanism, those postsynaptic mechanisms that were hindered take some time to come back, but they usually do come back. Next question. I've never heard of sodium dichloroacetate. I looked it up and it's expensive. For patients struggling with intermittent fatigue, pain, and sleep issues, could it help them sleep better and have more energy during the day? Yeah, so sodium dichloroacetate is one of these compounds. There's some studies on, I think there's about 6 or 8 papers in your course materials of research done on it. And it's hit or miss when they use it with patients with chronic fatigue patterns. Some have dramatic improvements and some have zero effects. And that's exactly how it is clinically. So you could easily have a patient spend $100 on this nutraceutical and they take it and have zero effect. So that's one of the negative aspects about this product. And then they can take it and have phenomenal responses and they're starting to unwind their pathway. So this is like we have the discussion, hey, this is something that's been shown to work with people that have this Warburg syndrome. It's hit or miss. It's one or the other. Do you want to take the risk or not? Because there's $100 or something. And different manufacturer, different costs, but it's never cheap. So that's one of the things in a real clinical setting that you have to have that discussion for. Okay, next question. What are the risks to children born to mothers with ME/CFS? So, well, this just goes into like prenatal health and how it impacts children, and many of the mechanisms involved with myalgic encephalitis chronic fatigue syndrome may have an impact on children. So for those that have autoimmunity, they are showing I'll show you this research in the next module, but many children that have autism have neurological autoantibodies. And those happen with mothers that have autoimmunity. So there's some autoimmune expressions that take place, and like cerebellum autoantibodies, myelin antibodies commonly occur. So some of these ME/CFS patients may have autoimmunity. There may be some increased risk for the children to have autoimmunity right off the bat. But there isn't any real good studies that I'm aware of where you see ME/CFS patients that have children with, let's say, autism or things of that nature. But there are studies that do show when mothers have infections, have immune regulations, that they do have higher rates of children suffering from autism than mothers that don't have infections during their pregnancy. So there is some shifts that are possible that take place there. And then, all the things with mitochondrial impairment and, people have the microbiome of the mother is going to impact the child's microbiome. When mothers have insulin resistance and obesity, the child ends up with long-term insulin resistance and sensitivity for obesity issues. Those are all the things that we're seeing with literature that's showing up. So yes, there are certain risks that happen. So, the key thing we talked about in the fertility course is not just to have a child, it's to have a healthy child. And you really want to, fertility isn't just about getting pregnant. Fertility is about getting healthy enough to have a healthy child. And, those are things we talk about in the Crosby Institute fertility course. Okay, next question. For patients prone to chronic dehydration from metabolic imbalances or living in dry areas, are electrolyte drinks mixes with stevia or monk fruit safe to use daily? Yeah, for the most part. I mean, some people don't like stevia. Some people like monk fruit. Some people are very sensitive even to those sugar spikes. But, it's safe. It's just some people may not tolerate it. So you have to realize that even though like monk fruit or stevia technically don't have this blood sugar spike, when they look at research, where you just think of eating something really, really sweet, like let's say a chocolate cake or a cookie or something like that, you actually have insulin secretion. So just the thought of something sweet does impact insulin secretion. So even though stevia and monk fruit technically don't impact blood sugar, of course they can, because they're sweet. So you could have some people extremely sensitive to it, and they still have blood sugar spikes. And even though they're, like you see hypoglycemics that become stevia junkies, and they take the little stevia bags everywhere they go, and they get iced tea, and they dump it all in there, and they order something and dump it all over. And for them, it still throws off their blood sugar levels, even though technically it shouldn't. So it depends on the patient, it depends on the use. Okay, next question. For someone who would like to make an impact on their fatigue and pain, is it worth investing in a cold plunge tub that stays clean and very cold, or a cold shower is sufficient? Cold plunge tubs would be the way to go. They have much more powerful effect than a shower. They're just expensive. So, there's cold plunge machines that can cost as much as $10,000, where they have a filter, it's always cold, it uses a lot of electricity, but anytime you want, you can go and do a cold plunge. So that's like the Rolls Royce, of these cold plunges, where the water's always clean, there's always ice in there, it's always fresh. And for some people that are athletes and train all the time, or have chronic pain syndromes, or relapsing or remitting MS, that's not a bad investment, because it does have a profound impact on their health and their recovery and the ability to function throughout the day. But you can also just go and get a plastic tub at Home Depot or your hardware store, dump some ice in there, jump in it every day to help with recovery and therapeutics. So cold plunge would always be better. It doesn't have to be these expensive machines, but a shower is like okay, but it's not going to be anywhere near the changes you get with a cold plunge. And with a cold plunge, you're in there for like 30 seconds to a minute, right? That's all you really need to start activating those endorphins and growth factors and peptides. If you stay in there longer and you start shivering, then you start impacting brown fat, and then you get changes in insulin resistance patterns, and you activate weight loss and other types of things. But even a 30 second to 1 minute where you just start to adapt and it feels comfortable and then you get out has some really powerful effects on inflammation and pain. Okay, next question. Is glycogenesis eventually permanently damaged from years of chronic health issues, blood sugar balances, and or aging? Okay, it seems a lot of long-term chronic health patients struggle with keeping their blood sugar up. Okay, so glucogenesis. Well, anytime when you look at when you look at blood sugar regulation, you have glucagon released. You have glucagon to get blood sugar levels back up. You have insulin to get blood sugar levels into the cell. You have cortisol to help break down glycogen and glucose. You have patients that get beta cell failures where they can't produce insulin. You get patients that get alpha cell depletion where they can't release glucagon. You get patients that have adrenal gland issues where their cortisol levels are compromised. So there's typically ability to have resiliency in these organ systems, but there are people that over years and years, they have inability to recover. So just like some people deplete their pancreatic beta cells and develop diabetes, there are people that deplete their pancreatic alpha cells and become long-term hypoglycemics. So those things do happen. Next question. How do you stay cool under a weighted blanket, as staying cool also supports sleep? Yeah, so that's one of the issues with some people that have weighted blankets. They just get really hot underneath there, and that's one of the most common reasons why people stop using weighted blankets. So you can just ventilate your room, and it just, some people will be able to tolerate, some people will not. And even if you don't sleep the whole night with the weighted blanket, if you take a little naps and put it on when you're just resting, it still has a very nice endocrine effect. So if you're watching like a Netflix video or some kind of movie and you use a weighted blanket, you still have some very good neuroendocrine immune effects. Okay. Next question. If poor mitochondrial function can cause depression and antidepressants can worsen mitochondrial health, what does the use of this medication look like over time in a patient with this pattern? Well, if you look at the medications that were listed as sources of causing mitochondrial uncoupling where they impact the complex enzymes, they're going to have different effects for different people. Some people are very sensitive to some certain medications. Part of it is because of their genotype. Part of it could be because certain complex enzymes may be more compromised than others. So for example, complex 2, where you have CoQ10, maybe they're on Lipitor, depleting CoQ10, and they're also on antidepressant, depleting complex 2. So that combination could be worse for one patient compared to another that doesn't have those issues. So it's a varied model. It's not so simple. So it could be all over the place. Next question. I have heard cases when ME/CFS ended up being due to structural or skeletal issues with skull and neck. Do you have more info on that and how to rule it out? I really don't know of anything related to skull and neck leading to ME/CFS issues. As a matter of fact, if there was skull and neck issues, I would really think of it as dystonia, and dystonia really would be brain-based, and brain-based is secondary to ME/CFS. So I don't know. Can you explain more about how bruxism is a neurological disorder and things that might correct it? Yes, bruxism is a multivariate model that actually increases clenching of the teeth at night. So if you look at the neurology of bruxism, there's actually the mesencephalic motor nucleus, or the trigeminal motor nucleus, and there's autonomic centers in the midbrain. If those things get constantly activated and not being inhibited, then you can have these patterns of bruxism. So this is actually an area of research I'm going into right now, and we're actually writing a review paper for bruxism. So as soon as we finish that review paper, I'll put it up in our resources, like our Facebook page. Okay, next question. If someone is limiting their mobility or limping due to pain, how do they know whether it's safe to push through the pain, that they should be careful or not to further injure or damage a joint or other area? Right, so it depends on what's causing their mobility. If they have degenerative joint disease and inflammation, they probably didn't want to push past their pain. If they just have like myofascial trigger points and fibrosis, then they need to push past their mobility. The key thing is really going to be recovery. So as long as they're not getting more injury, then then you probably it'd be okay doing it. Okay, thank you all for asking the questions. Thank you all for taking the course, and I hope you found something useful to impact your patients and maybe even yourself. Thanks again.